Okay, excellent. Well, let's begin. I can see we've got a full session here for the next 30 minutes or so. My name's Carl Pringle. I'm with Genexus Healthcare Systems, and we're going to talk about 5 steps to reducing healthcare costs with pharmacogenetics. That's quite an expansive topic. We're going to keep it to 20 minutes and then have some Q&A after that. And we'll be looking both at pharmacogenetics as it stands today, but we'll also be looking at pharmacogenetics in the context of next generation. So the reason why this has come to be over the last few years is that there's been a substantial increase in costs within the employer setting, as well as just in general society of healthcare. If we look at some recent studies that have been done, it's nearly $1,400 of prescription drug spending per employee per year. This cost is enormous. And you know, if we kind of sit back and look at the bigger picture here, 50% of prescriptions are ineffective. They don't work as expected. And we know this because we all are used to this situation where we go and see a doctor and we're given a prescription with the following caveat. Try this, and if it doesn't work or you develop a cough, come back and we'll try something else. It's trial and error. So pharmacogenetics is all about starting to be able to eliminate that. But the interesting thing is pharmacogenetics all by itself cannot do it. There's a lot of other variables and factors that need to be taken into account. And that's really where the next generation of pharmacogenetics is going. So we'll talk a little bit about that in a bit. So not only are 50% of prescriptions and drugs ineffective in what they do and someone has to try something else, last year in the US, the 4th largest cause of death was adverse reactions, and this is the same in every other Western country around the world. To put it into slightly more graphical terms, it's equivalent to a 787 plane crashing yesterday, today, tomorrow, the rest of this week, next week, every week this year. In the broadest sense of the word, it's a global pandemic. The good news is when we bring it down to an employer setting, there are solutions and ways to really reduce the cost and employee and employer burden within the within your organization. So if we look at some of the problems that need to be addressed and are addressed with this approach of pharmacogenetics and precision prescribing, it's really focused on reducing absenteeism, both in terms of duration and rate, the same with presenteeism, lost productivity in the workforce, and the ballooning healthcare cost situation. So by reducing the amount of medications, increasing the effectiveness of the medications that are prescribed, increasing patient safety, we're able to reduce both the claims as well as healthcare costs. So what this ultimately means is that within the workforce, you've got an improved population health, employee retention is improved, as well as actually attracting employees from the outset in a very highly competitive hiring situation that we have today. Everyone is looking for different innovative benefits that are going to attract and retain employees. And this also reduces the cost burden, both for the employer as well as the employees' out-of-pocket expenses. So it's all about replacing trial and error, the trial and error approach to medication. So with that, I would really like to now hand over to Professor Dawes. Professor Dawes is a professor of family medicine at the University of British Columbia. He's also done extensive work in clinical evidence and is a leading international expert in pharmacogenetics. Martin, over to you.
Thanks very much, Carl. So welcome, everyone. My name is Martin Dawes, and so what you're looking at there is Pharmacogenetics 101. It starts with a cheek swab. In this case, it's a and we've done a lot of work to identify what is the best way to actually extract some DNA from an individual. The next part of the 101 is what does actually this look like? And for me, as a family physician, I was quite surprised that that thing that looks like a wine fridge behind the scientist there is actually the something called a qPCR machine that actually does the pharmacogenetics. So not a huge machine and not a huge amount of space, but the real skill lies in the brain of that scientist, because although you can buy these machines, actually creating the tests and the accuracy is really, really hard. So what are we talking about when we get to pharmacogenetics? Well, there are three tests that are generally done. The first is this thing where a single replacement of a base nucleotide in your DNA happens. And what's remarkable is that can make a huge difference. So a single replacement of something as tiny as one base nucleotide can actually really impact the drugs you're taking. In this example, I say, well, it could be a moose, because we come from Canada, obviously we use Canadian animals, and substitute one letter and you get a mouse. It might be that you expected to have a single espresso and your metabolism actually makes it feel like a double espresso, which isn't so bad. But if it was a drug to reduce heart rate and I expected your heart rate to go from 90 to 60, but because of this variant, it went from 90 to 30, that is obviously a potentially fatal problem. The second group is copy number variance. This is where you expect a sequence of base nucleotides, but actually it's repeated several times. And my analogy here is that you expect one mouse and you get a whole lot of mice. And again, this can impact the way that you're metabolizing drugs. And the third one, where I put no pictures, is an HLA variant. Very rare to see companies do. It's very hard to do, but boy, do these differences make a tremendous impact on an individual. Basically, if you take a drug and you've got one of these variants for that drug, your skin sloughs off. Now that's not so bad, maybe, but it's the skin of every organ of the body potentially. So it's fatal in up to 30% of people. And these drugs are common. It's allopurinol for gout, so it's not like it's a rare drug. But that's not the only issue. As Carl mentioned, that we've got a lot of other things to take into account. And basically, a family physician generally has to go through about 200 to maybe 1,000 facts to identify which drug is effective and optimal for an individual, and doesn't have the time, so resorts to trial and error. In fact, it's almost impossible to, within a consultation, to identify all the facts. But all those facts can be into algorithms. At the moment, we reckon that 50% of adverse drug reactions are preventable using algorithms. What I mean about that is, well, we'd just do with the pharmacogenetics first. It's not a new intervention at all. This technology has been available for over 50 years. We've got guidelines around the world. We have more than 400 randomized controlled trials. So this is mainline. The problem is, how do I use it in my clinical practice? And what we've done is determined at the university that you could actually take all these elements and create a platform, very smart software algorithms, and a physician or a pharmacist or even a patient can enter the condition, enter some information about the condition, which maybe takes a minute or two, press a button, and there are the drug options adjusted for absolutely everything, really simplifying the process of prescribing. And it's interesting, it's taken pharmacogenetics to make us realize that we could have done this quite a long time ago, before pharmacogenetics, and maybe not had those problems of adverse drug reactions being the fourth cause of death.
Great, Martin. Thanks for that background into pharmacogenetics and next generation of pharmacogenetics leading to precision prescribing. I think putting that in the context of how we started with the cost burden that employers have, the rate of absenteeism in the workforce, having this kind of technology is amazing and really does help employers in what they need to do, which is increase profits, reduce costs, but have a very healthy workforce employee population. And it's no wonder that over the past 12, 18 months, we've seen a significant increase in the interest in pharmacogenetics and precision prescribing and how that can be used within the workforce. In fact, only this week, we saw yet another study and reference from SHRM, the Society for Human Resource Management, specifically talk about precision prescribing and how it can be utilized in the workforce. So what we're commonly asked is, well, this sounds really good, but how do we actually do it? How do we get started in our setting. We may have 30, 40,000 employees around the world, or perhaps we only have 1,000 and they're all based in Washington. So really, here are 5 steps to success for an employer that we see in how they roll out precision prescribing and pharmacogenetics. So the first one is, don't try and boil the ocean all at once. Do some degree of risk stratification. And the reason for this is, one, it keeps your costs, your initial costs contained. It allows you to work out some processes that work, tweak them before you then go to the next level of your employee base. So risk stratification is key. This also will allow you to get a positive return on investment. Focus on the highest risk employees where you have the biggest cost burden. You'll get the biggest return on your investment, enabling you then to expand it out to the rest of your organization. The second is around education and awareness. And what I mean by this is, it's about educating your employees and making them aware of this benefit, because like any benefit, you actually want your employees to take advantage of it, particularly if it helps you as an employer. And in this case, there's big benefits both to the individual, but also to the corporation. So you need to do a well thought out education and awareness communication plan for your employees. Talk about the benefits to them and to their function, their group that they work within, as well as the benefits. Be upfront with the benefits to the organization. And there are some key things that they will be concerned about that you need to broadcast in your communication. And there are things like confidentiality of information. And another typical one we see is that this is not a diagnostic tool. Pharmacogenetics is not about telling someone whether or not they are going to get cancer next week. It's around the interaction of their body and medications that they take. The third piece is around accessibility. And what I mean by this is making the process and the ability for the individuals to do the test and have access to the software easily. So by providing information online, maybe having the kits, you can order them or download them, get them sent to your house or to your workplace online or at a health center, local pharmacy, or perhaps you have them within your workforce as well. So just making it easy for people to be part of the process and to benefit from the benefit. The fourth one is around impact data. And this is for the employer, and this is about being able to see aggregated, anonymized data so that you can make future decisions on how you roll this out to which groups, the return on investment, and perhaps be able to change some of your work processes based on the information that you're seeing. And it ties very closely with claims data if you have the ability to see that as well through your broker. And then the fifth step for success for employers as they roll this out is the further rollout and the expansion of it, and really going back and refining the processes, maybe use some KPIs just as you would for other processes to measure your success as you go through the process. So it links in very neatly with the first few key steps for success of risk stratification and the education and awareness. So tweak those, refine those, and go forward. And of course, you know, as experts in doing this and helped organizations get their thinking around how they deploy it, we're open to helping organizations in their thinking on this, and definitely around the return on investment and how to model that, as well as risk stratification tools. So we have tools and techniques that we're happy to help everyone with. Our contact information is here on the screen, and of course our website is straightforward at www.genexus.com, and we've got a LinkedIn account where we have all sorts of information, and we publish the latest guidelines, links, information, studies, etc., that have been done in this area. So that's me finished, and I think we're bang on just shy of 20 minutes, so very good time. I can see a few questions coming in already, and so one of these questions, Martin, I'm going to ask this question of you, just so everyone has a different voice to hear from. What do you see as the typical barriers to rolling out this within an organization? And this question comes from a beloved international software company that's based on the East Coast.
So thanks, Carl. I love being thrown questions without any warning. And the message that we've really developed is about education. The last thing I want as a doctor is to be thrown something that I appear not to know anything about in front of a patient. That is just about the worst thing that can possibly happen. And then if a company puts me in that position, either an employer or a testing company, that is not great for me. It's not great for the person trying to offer the service, whether it's a test or a new drug, whatever it is. So education is going to be key. Education for the employees, education for the people who are going to provide the interpretation of the data, the use of the software, etc. So we've got to be pushing that out, and I think it's really important for a company to think about that. Confidentiality, we're all bound by FIPA and HIPAA, but we need to make it clear that none of this genetic information is going to be used willfully by other organizations. And establishing that, even though this is just pharmacogenetic information, patients often think it's just genetics, that it's all their DNA. So making certain those confidentiality processes are displayed and available to the users is really important. The third point that Carl, talked a little bit about is being scared about the results. So is this going to tell me I'm going to have Alzheimer's in 5 years? No, it's not. But again, it's really important to get that message out to the people who may be using it. The final part I would say is who can see that information. Actually, I think it's really important when it's genetic information that I should be able to share it with as many health professionals as I think appropriate. So this is my information. If I'm in an emergency room, I want to make sure that I'm not given codeine because it actually causes me immense problems because of a variant. I need that information to be there with that emergency room physician. If I'm seeing someone, my cardiologist, again, I need my cardiologist to be aware. So I think what I would say as a rollout process is make sure that whoever you work with, they can actually establish links with whichever clinician group the patients need to have this information shared with.
Great, thanks, Martin. We have another question that's come in, which is around the stratification and the return on investment. And the question is, how long does it take to do a risk stratification and a return on investment for ours? And thanks, Mercer, for the question. So the good news is that it doesn't take very long to do, and the even better news is it doesn't cost anything. So typically a risk stratification process will take a couple of hours to go through. We've got a tool that will help you do that, and you can put in some of your own information to come out with the results in terms of who to roll this out to begin with. And this actually will also tie into the return on investment model. So we can do a return on investment model against the national averages for your employee base as a whole. We can also do it on specific groups. So whether it's a functional group, a geographical group, or indeed a high-risk stratification group. So great question on that. Another question has come in, and this question is about 23andMe, and the question is, how does this differ to 23andMe, or does it link to 23andMe? So they're actually two very different worlds. 23andMe is very much focused on hereditary and ancestry type information and whether or not you may like certain flavors of food. So it's really, for me, that's genetic entertainment. And what has been great about 23andMe is that they've really educated the marketplace and individuals that genetic testing is not a dangerous thing to do. It doesn't involve blood being drawn. It's saliva based. So really that's the biggest focus. What we're focused on is not the ancestry, not the hereditary, not predicting diseases. What pharmacogenetics and Genexus is focused on is about the medical application of knowing about your genetics in terms of what medications are going to work for an individual so that they can get better as quickly as possible and get back to the workforce.
I mean, I'd just add a little bit to that. If I'm a company and looking at exploring this, I gave you the hints that you've got to be looking for 3 tests. So if you're looking at 23 and me or anyone else, ask them, do you do a panel of SNPs? Do you do copy number variants? And if so, which ones? And do you do HLAs? And if they're saying no to HLAs, then there's a question to be asked, or no to copy number variants. Why not? And are you planning on putting that on your panel soon? Because you really want a comprehensive approach when you're doing this. Again, it's about the message to your employees. If the employees think you're giving them a comprehensive panel and actually it's missing things, then we're not offering maybe as comprehensive service as we should.
Great. The next question is from Unilever, and their question is, does the employer see individual employee information and data? So the answer is absolutely no. The employer does not see the genetic information of the employee, and in fact, the employee, once they have their genetic test done via the cheek swab, they are in charge of their data and who sees that data at that point. So they can invite their healthcare professionals, family members, etc., to see their genetic information should they wish. The employer only is able to see the impact data, which again is aggregated and anonymized data to help them with future rollout, doing return on investment models, and also making decisions on how they may adapt, refine, and change their workforce environment and their workforce processes to help reduce and in response to the aggregated data and the learnings that they get from that. So I think that's it in terms of the questions coming in. We've finished a little bit ahead of time. Professor Dawes, thank you very much for your insight. And for everyone on the line, thank you very much. We will have another session in late January where we'll take the role of pharmacogenetics and precision prescribing in the workforce one step further. And with that, I wish everyone a very Merry Christmas and Happy Holidays to you all. Thank you very much. Over and out from Genexus.